In this video, we will discuss the investigations and management of thyroid eye disease. Investigations other than thyroid function tests are not required if the diagnosis is clinically evident. However, exclusion of other conditions may be necessary. Visual field testing is done when optic nerve compression is suspected, and baseline evaluation may be performed even without visual impairment. Imaging in thyroid eye disease. MRI, CT, and ultrasonographic imaging of the orbit are indicated in selected cases to confirm diagnosis. It helps to assess the typical pattern of muscle belly enlargement with tendon sparing. Imaging is also used to assess optic nerve compression and before orbital wall surgery. Visual evoked potential may be utilized in optic neuropathy. Treatment of thyroid eye disease is classified into that of mild disease, moderate to severe active disease, and post-inflammatory complications. Smoking cessation and proper management of thyroid dysfunction are essential. When radioiodine is used, a short course of oral steroids should be given concurrently. Management of mild disease. Lubricants for superior limbic keratoconjunctivitis, corneal exposure, and dryness. Topical anti-inflammatory agents such as steroids, NSAIDs, cyclosporin. Head and elevation during sleep with 3 pillows to reduce periorbital edema. Eyelid taping during sleep for mild exposure keratopathy. Moderate to severe active disease. The UGOGO recommends calculating the clinical activity score. It aids in determining the threshold for the use of immunosuppressives. 1 point is given for each feature, and treatment is considered if score is greater than or equal to 3. The components of clinical activity score in the initial visit are spontaneous orbital pain, gaze-evoked orbital pain, eyelid swelling, eyelid erythema, conjunctival redness, chemosis, inflammation of caruncle or plica. 1 point is given for each feature, and treatment is considered if score is greater than or equal to 3 out of 7. During subsequent review, a point is allocated for an increase in proptosis of 2 mm or more, a decrease in uniocular exertion in any one direction of 8 degrees or more, and a decrease in Snellen acuity of 1 line. Treatment is considered if score is greater than 4 out of 10. Systemic steroid therapy. Systemic steroids are the mainstay of treatment for moderate to severe disease. Oral prednisolone 60 to 80 mg per day may be given initially and tapered depending on the response. Intravenous methyl prednisolone is often reserved for acute compressive optic neuropathy, but tolerability is better and outcomes may be superior compared with oral treatment. A low-intensity regimen in the absence of acute sight-threatening disease is 0.5 gram once weekly for 6 weeks, followed by 0.25 gram once weekly for 6 weeks. A reduction in discomfort, chemosis, and periorbital edema usually occurs within 24 hours, with a maximal response within 2 to 8 weeks. Orbital steroid injection. Orbital steroid injections are occasionally used in selected cases to minimize systemic side effects, but they are less effective than systemic treatment. Low-dose fractionated radiotherapy. It is used as an adjunct to steroids or when steroids are contraindicated or ineffective. They have a delayed onset of action, due to which they are not the first line for acute optic nerve compression. A positive response is usually evident within 6 weeks with a maximal improvement by 4 months. Around 40% will not respond. Adverse effects include cataract, radiation retinopathy, optic neuropathy, and an increased risk of local cancer. Optic neuropathy. Optic neuropathy and intractable corneal exposure require aggressive treatment. Pulsed intravenous methylprednisolone is commonly used. The regimens are 0.5 to 1 gram on 3 successive days, followed by 40 mg per day oral prednisolone, or 0.5 to 1 gram on alternate days 3 to 6 times with maximum dose below 8 gram to reduce risk of liver compromise, followed by 40 mg per day oral prednisolone. Appropriate monitoring should be instituted, including liver function tests as well as gastric protective treatment and osteoporosis prophylaxis if necessary. Orbital wall decompression or orbital apex decompression may be considered when steroids are ineffective. About 20% of patients receiving intravenous steroids require decompression. Orbital radiotherapy is generally used only as an adjunct. Post-inflammatory complications. Eyelid surgery should be performed only after necessary orbital and then strabismus procedures have been undertaken, as orbital decompression may impact both ocular motility and eyelid position, and extraocular muscle surgery may affect eyelid position. Proptosis. After inflammation has remitted, patients may be left with significant proptosis. Treatment is surgical. Surgical decompression increases orbital volume by removing bony walls and orbital fat. Most surgery is undertaken via an external approach, while medial wall and the medial part of orbital floor may be reached endoscopically. One wall decompression involves removal of deep lateral wall. It gives 4 to 5 mm reduction and a reduced risk of post-operative diplopia. Two-wall decompression involves removal of the medial and lateral wall. It gives a greater effect of reduction of proptosis, but a higher risk of diplopia. Three-wall decompression removes medial and lateral wall and floor of the orbit. It gives 6 to 10 mm reduction but has a higher risk of hypoglobus, infraorbital nerve damage and diplopia. Four-wall decompression involves removal of the medial, lateral wall, floor and part of the roof, which is required in very severe proptosis. Restrictive myopathy. The indications for surgery are persistent diplopia in primary and reading gaze, inflammatory phase has subsided, and angle of deviation is stable for at least 6 to 12 months. Until these criteria are met, diplopia is managed with prisms or botulinum toxin. The goal of surgery is to achieve binocular single vision in the primary and reading positions. Recession of the inferior or medial recti is the most commonly indicated surgery. A rectus muscle is never resected, only recessed in thyroid eye disease, generally utilizing adjustable sutures. The suture is adjusted later, the same day or on the first postoperative day to achieve optimal alignment, and the patient is encouraged subsequently to practice achieving single vision with a consistently accessible target such as a television. Lid retraction. Lid retraction may improve spontaneously in mild cases. Control of hyperthyroidism may be beneficial. Botulinum toxin to levator aponeurosis and Muller muscle can be used as a temporary measure. Mullerotomy is effective for mild lid retraction, but more severe cases may also require recession or disinsertion of the levator aponeurosis and the suspensory ligament of the superior conjunctival fornix. Retraction of lower lid of greater or equal to 2 mm requires recession of lower lid retractors with or without a hard palate graft. To summarize, CT or MRI shows the typical muscle belly enlargement with tendon sparing. Smoking cessation and control of thyroid dysfunction is essential in all patients. In moderate to severe active disease, immunosuppression with systemic steroids plus or minus radiotherapy is essential. Optic neuropathy requires pulsed IV medial prednisolone, and if there is inadequate response, orbital or apex decompression can be considered. In post-inflammatory stage, surgical correction of proptosis, restrictive myopathy, and lid retraction can be considered.